بابا راح احضر المحاضرة.
薛主任，听到吗？
哎，
好，行，我把他们全静音了，然后那个不然太吵。
好嘞。
两位主任，你们介意稍微再多等2分钟吗？因为我看现在还有很多人没进来，他们那边可能，他下午可能医院在上班，但是我现在已经在刚才会议之前我已经在催他们来参加了。
没关系，没关系。
某个有一个你看，或者是妈妈肚皮。
那个。
iPhone 是
等着就。
是某个。看名字。
什么还是不多？
他们说现在多管理。那个不就像是？
是。从头开始。他们老外的时间观念不像我们中国人这么这么守时啊，他们。 我们现在先开始。先开始。听主任，然后谁主任？哎，两个主任，我们现在先开始吧。我们先开始，然后他们后面医生会慢慢进来。
好的。
好，行，那我先来做一个简短的那个介绍哈。Okay, hello. This is Rin from China. I represent our company Eco Medical and CCMA to welcome all of you to join this webinar. As is known, CCMA, short for China Conference on Microwave Ablation, is committed to building the world's top tumor ablation academic exchange and multi-party cooperation platform. As world-leading microwave ablation manufacturer, we EcoMedical hopes to make contribution to the global minimal invasive ablation course. I'm sure most of you are experienced in liver and lung microwave ablation. However, the thyroid ablation is probably new to you. But in China, thyroid ablation is very popular and the treatment effect is satisfying. Today, we are honorable to invite two China top-level doctors in this field to share their successful experience. The first is Dr. Cui Guoqing, the medical doctor, deputy director of ultrasound department of China, Japan, Uni Hospital of Jilin University. Can you say hi to all of them, Dr. Cui?
Hello, 大家好。Hello, everybody.
Okay, thank you. The second one is Dr. Chen Dengke, the medical doctor, deputy director of ultrasound department, China, Japan, Uni Hospital of Jilin University. Dr. Chen, can you say hi to them?
Hello, everyone.
Okay, thank you. Now let's start this webinar. Start from Dr. Cui Guoqing. Let's welcome Dr. Cui Guoqing to give his lecture on microwave ablation for benign thyroid nodules. Dr. Cui, please. Okay, I'll set you to the host.
让我共享一下屏幕。
好的。那可以了，崔主任。
Hello, ladies and gentlemen. My name is Cui Guoqing from Department of Ultrasound, China Japan Uni Hospital of Jilin University. And today, I would like to report to you on the efficacy and safety of microwave ablation for the treatment of benign thyroid nodules. My report mainly covers 6 aspects: background, methods, follow-up, complication, case, conclusion. In recent years, the prevalence of thyroid nodules has increased annually. The detection rate of thyroid nodules has increased to 65% in the general population, and 90 to 95% of the nodules are benign. In most cases, benign thyroid nodules are simply followed up and monitored. However, some benign nodules may require treatment when patients have related symptoms or cosmetic problems. What kind of treatment should be taken for these nodules? The 2015 American Thyroid Association Management Guidelines for adult patients suggest that surgery may be considered for benign thyroid nodules if they are large, causing compressive or structural symptoms, or based on clinical concern. Although surgery is widely used and effective, It may be associated with significant incidence of post-operative complications and unsatisfactory aesthetic effects. Some patients must take medications for life after surgery, which affects their mental health and quality of life. Therefore, increasing numbers of patients are seeking a minimally invasive treatment alternative to surgery. Thermal ablation methods such as laser, radiofrequency, and microwave ablation are being used more extensively in clinical practice due to their advantages, such as reduced trauma and no scarring. MWA is characterized by rapid heating, good coagulation, a large ablation area, and a relative ease of use, and is currently used to treat liver, kidney, lung, and breast lesions. In recent years, researchers have gradually adopted the use of MWA to treat thyroid nodules. Studies have shown that ultrasound-guided MWA is safe and effective for the treatment of benign thyroid nodules. Moreover, researchers have investigated MWA with a surgery for the treatment of benign thyroid nodules. Their studies have suggested that MWA can significantly reduce nodule volume and nodule-related symptoms and provide a faster recovery and more satisfactory aesthetic outcomes with less physiologic disruption and a lower cost compared with surgery. Microwave is a kind of high-frequency electromagnetic wave, polar molecules in tissues will oscillate and collide with each other under the action of microwave to generate heat energy. The current microwave therapeutic apparatus can form an ellipsoid solidification zone with a diameter of about 3 to 4 centimeters, a central temperature of over 100 degrees Celsius, and a peripheral temperature of 54 to 60 degrees Celsius. One or more of the following inclusion criteria needed to be satisfied. The nodules are associated with pressure symptoms or clinical concern. Treatment was sought because the nodule affects the patient's experience. Clinical observation as a treatment approach was rejected due to the patient's concern about the effects of the nodules on normal daily activities. The nodule volume increased rapidly. The following three are exclusion criteria: abnormal contralateral vocal cord, severe coagulation disorders, severe cardiac or pulmonary disease. The ablation process requires an ultrasound device with CEOS function. Sonovil was used as the ultrasound control agent, which was diluted in 5 milliliters of 0.9% saline and mixed well by shaking before use. A 4 milliliter bolus was injected into the median capital vein. The MWA instrument we used is Eagle machine, superficial organ ablation needle, made in Nanjing, China. All patients signed an informed consent form before MWA, and all patients were confirmed to be benign thyroid nodules by core needle biopsy. All patients underwent laboratory tests before treatment. including thyroid function and thyroglobulin antibody and coagulation. Patients taking anticoagulants were required to discontinue these medications 1 week before treatment. All patients underwent routine ultrasonography before treatment to evaluate nodule size, location, composition, and vascularity before MWA. We developed the treatment protocol according to the volume of nodules and predicted the required number of ablation layers and needle insertions. CEOS was performed before MWA to determine the location of nodule feedings arteries and develop an optimal ablation pathway. If the nodule was next to the epsilateral recurrent laryngeal nerve or large vessels in the neck, we used the hydrodissection technique under ultrasound guidance to separate the nodules from the trachea, esophagus, common carotid artery, internal jugular vein, and recurrent laryngeal nerve before ablation. If the ablation power is set to 30 watts, 1 minute of ablation can form a 5 multiple 7 millimeter ablation area. According to the estimated results, the multiple overlapping shot technique was used to perform ablation layer by layer. For each layer, ablation was performed from deep to shallow surface and in a distal to proximal dissection. When the ablation position was confirmed, MWA was started after the full active tip was placed within the nodule, and the initial power was set to 25 watts. The electrode was not moved at the beginning of MWA until the nodule showed an obvious hyperecho vaporization area. Once a part of the nodule had been treated, the antenna was repositioned next to the previous ablation area, and ablation was started again to create overlapping ablation zones. This process was repeated until the hyperecho zone of vaporization covered the whole thyroid nodules completely. During the procedure, the physician communicated with the patient regularly to monitor any intraoperative complications, such as hoarseness and pain, to prevent damage to the recurrent laryngeal nerve. CEOS was performed immediately after ablation to evaluate the ablation area. Ablation was completed once the lesions had been completely inactivated and no residual lesions were observed otherwise. Ablation was repeated. Follow-up. After MWA, the patients were followed up for 12 months. The ultrasound examination are evaluated at 1 day and 1, 3, 9, 6, 9, and 12 months after MWA, and laboratory tests, symptomatic and cosmetic scores are evaluated at 1 and 12 months after MWA. Ultrasound examination include volume and volume reduction rate. The following three are the possible complications during the MWA. The hoarseness will disappear after 1 to 3 months. When bleeding and pain are present, use a homeostatic and a painkiller respectively. Let's look at this case. A female, 54 years old, color Doppler ultrasonography showed a large mass in the right lobe of thyroid gland with a size of 6 multiple 4.2 multiple 5.7 centimeter and a volume of 74.9 cubic centimeter. Starting from the root of the nodule. The nodule was ablated. The ablation power was 25 watts and the time was 40 minutes. During the ablation, the working area of the recurrent laryngeal nerve should be avoided to avoid the injury. CEUS was performed immediately after ablation to evaluate the ablation area, a black hole. One month after MWA, the ablation area was 51.3 cubic centimeter in volume. The VRR after 1 month was 32.4%. 3 months after MWA, the ablation area was 32.6 cubic centimeter in volume. The VRR after 3 months was 56.5%. 6 months after MWA, the ablation area was 19.9 cubic centimeter in volume. The VRR after 6 months was 73.7%. Look at this case, a female, 53 years old. Color Doppler ultrasonography showed a large mass in the left lobe of the thyroid gland with a size of 4 multiple 3.7 multiple 2.6 centimeter and a volume of 20.1 cubic centimeter. Starting from the root of the nodule was ablated. The ablation power was 25 watts. This layer completed. We will ablate next layer. The whole time was 20 minutes. During the ablation, the working area of the recurrent laryngeal nerve should be avoided to be injured. CEUS was performed immediately after ablation to evaluate the ablation area. One month after MWA, the ablation area was 8.7 cubic centimeter in volume. The VRR after 1 month was 57%. 3 months after MWA, the ablation area was 4.8 cubic centimeter in volume. The VRR after 3 months was 76%. 6 months after MWA, the ablation area was 2.3 cubic centimeter in volume. The VRR after 6 months was 89%. 12 months after MWA, the ablation area was 1.4 cubic centimeter in volume. The VRR after 1 year was 93%. Now we come to the conclusions. MWA is a safe and effective treatment for benign thyroid nodules. MWA is characterized by a faster recovery, fewer complications, better protection of thyroid function, and superior aesthetic results relative and may become an alternative to surgery in clinical practice. This is our team of ultrasound intervention. The above is what I want to introduce. Thanks for your listening.
Okay, thanks. Thank you, Dr. Sui, to give this wonderful lecture. And I saw that the doctor asking question here, but our doctors will answer question in the final part, the QA part. Okay, so I will collect all the questions, and also you can ask questions in the QA part. Now let's welcome Dr. Chen Ke to share his successful experience in microablation for papillary thyroid microcarcinoma. Please, Dr. Chen.
Hello, everyone. I'm Dr. Ke from the Department of Ultrasound, China-Japan Union Hospital of Jilin University. What I introduce to you today is the efficiency and the safety of microwave ablation for treatment of papillary thyroid microcarcinoma. At present, thyroid nodules has a high incidence rate with 68% in the world. However, the latest study shows that only 12 out of every 100,000 people in China is thyroid cancer. Despite its high incidence, the mortality rate is low at 0.5 of every 100,000 people. This suggests that the prognosis of thyroid cancer is relatively good compared with other malignancies, and that the papillary thyroid microcarcinoma is better. In the past, surgery was the main treatment method for papillary thyroid carcinoma, which was called PTMC. But it had many complications and affected patients' quality of life. Many doctors in the world has begun to recommend the method of active surveillance. which can avoid injury to the thyroid from surgery. But the main concerns of active surveillance, which was called AIs, lies with the anxiety experienced by both patients and the physicians due to indwelling cancer. In large population study evaluating the outcome of AIs, a substantial number of patients were lost of follow-up, which may overestimate the outcome of AIs. And it may be speculated that patients' anxiety contributed to follow-up loss. Therefore, many patients on AIs undergo delayed surgery. Ultrasound-guided thermal ablation modalities represent an intermediate approach between AIs and surgery for patients with PTMC. Thermal ablation includes radiofrequency, laser, and microwave ablation. Today, we are going to focus on microwave ablation, which was called MWA. Next, let's review the history of microwave ablation of PTMC. In 2014, there was the first report on microwave ablation in the treatment of PTMC. This was an experience reported by a team from China, which achieved good effect. However, thyroid cancer is a kind of slow onset disease, which requires a longer time to observe the efficiency. In 2018, the first long-term follow-up study on microwave ablation of PTMC was published with a follow-up period of more than 3 years. This article was published by our team. In 2020, a systematic review and meta-analysis was conducted. This systematic review confirmed that microwave ablation is safe and effective in the treatment of PTMC. At the same time, in 2020, there are 3 papers on follow-up studies of more than 5 years. There are 2 papers on radiofrequency ablation for PTC, and 1 paper on microwave ablation for PTMC, which was also published by our team. The 3 papers were published simultaneously in the journal Thyroid, which is the official journal of American Thyroid Association, and the journal is now paying close attention to these treatment methods for long-term outcomes. By 2021, a meta-analysis based on the above 3 articles with 5-year follow-up was published in the journal European Radiology. The conclusion of this article shows that thermal ablation is also safe and effective for low-risk PTMC. But what do we treat PTMC by microwave ablation? What is the process? First of all, pre-operative evaluation is required before treatment. We needed to determine the location and size and the volume of the lesion, calcification, blood flow, and other conditions. According to these conditions, we need to design the puncture route, the ablation area, the level, and the number of punctures. For a nodule about 5 millimeters, we do 3 layers of ablation and 5 antenna insertions. Schematic diagram of the 5 antenna insertion performed during the ablation of a lesion about 5 mm in diameter. An ablate strategy to ensure that the tumor is completely ablated and reduce the risk of recurrence. The first 3 antenna insertions are performed to ablate the largest cross section of the lesion, which is on the top of the diagram. The antenna is inserted into the subcutaneous tissue. Then the direction of the antenna is adjusted in the thyroid tissue of subcutaneous tissue to insert the antenna into the dorsal area of the lesion, close to the normal tissue. The central and the ventral area of the lesion near the normal tissue are sequentially ablated. After ablation of the largest section of the lesion is completed, we withdraw the antenna from the ablation area to the thyroid or the subcutaneous tissue and adjust the direction for fourth insertion of the antenna into head region near the edge of the lesion for ablation, which is shown in the middle diagram. Finally, the fifth insertion is performed by inserting the antenna into the foot region near the edge of the lesion for ablation, which is shown at the bottom diagram. The next step after anesthesia is done, we have to ablative protection of the surrounding vital organs or nerves, for example, trachea, esophagus, recurrent laryngeal nerve, and so on. Normal saline is needed as hydrodissection. Look at this. This is how the hydrodissection is injected. Here is the needle.
它那个是哈，你的那个技术阻止血肿的形成呢？囊是否容易理解怎么阻止血肿的形成？
或是 inject. The ablation technique is usually fixed ablation combined with moving short ablation.
然后穿刺的时候尽量避开血管。
The ablation technique is usually fixed ablation combined with moving short ablation. The range is at least 2 millimeters beyond the edge of the tumor to ensure a radical effect, reducing the chance of recurrence. Here is the process of ablation. Was ablated.
对呀，首先超声及超声导演明确，血管位置，穿刺避开血管。
Post-operative assessment of ablation is generally evaluated by contrast enhanced ultrasound. It can be seen whether the ablation effect is satisfied.
你把这个有噪点可以。
You can see here is the ablated area. The tumor was totally inset in the area of ablated. Let's look at the example of process of MWA. 0.36 multiplied by 0.3 centimeter hypoechoic nodule is seen dorsal to the right lobe of the thyroid gland. The diagnosis of FNA was PTMC. Before MWA, a contrast-enhanced ultrasound was performed. The CEUS, which was called contrast-enhanced ultrasound, shows that the nodule is hypoperfusion. Here is the nodule. The nodule was near the trachea and the recurrent laryngeal nerve. The second video is intraoperative ablation. First of all, we need to inject normal saline as hydrodissection to protect the recurrent laryngeal nerve from burning. Here is the needle which was injected around the thyroid tissue. Now the nodule was protected by the normal saline. After hydrodissection, we will begin to start the ablation. Here is the nodule. Here is the nodule. Now the antenna was injected into the tissue. Here is the antenna. Then the antenna was injected into the nodule. When the antenna was located on the right position, we will begin the ablation. Now the ablating is began. Okay, now the ablating is finished. After the MWA is finished, we will perform another CEUS. The ablated area was no perfusion. Here is the ablated area. And we can see that the tumor is completely contained in the ablated area. The most common post-operative complications include pain and hoarseness due to recurrent laryngeal nerve injury, skin burns or infections, and parathyroid gland damage, which is very rare. A recent meta-analysis showed that the average complication rate was 3.6%, with a minor complications rate of 2.4% and a major complication rate of 1.2%. This shows that it is still a very safe method. And then we look at the follow-up. Follow-up was performed at 1, 3, 6, 12, and every 6 months thereafter. Follow-up included the post-operative ablation area size and volume, cervical lymph node, and the thyroid function. Total body ultrasound and lung CT were performed every 6 months to determine the presence of distant metastasis. During follow-up period, the size of the nodule showed a trend of diminishing. At the first month after MWA, the volume of ablated area in journal is increasing. It's because we made a post-operative expanded ablation. Usually 2 mm, even achieve 5 mm. By the third month after MWA, it's usually flat, and then by 6 months, it's going to have significant decrease, and after that, it's going to decrease more and more. According to the long-term follow-up results, the most of lesion can achieve a complete disappearance. Therefore, microwave ablation for PTMC is a very effective treatment method. So let's look at some cases. This is a young woman. After being diagnosed with papillary thyroid carcinoma, refused surgery for cosmetic reason and requested for microwave ablation. During the operation, we performed the expanded ablation, and 1 month after the operation, we observed that ablation area is significantly larger than the lesion. 3 months after ablation, the volume reduction rate reached 36%. 6 months after ablation, the lesion was absorbed completely. Now the patient has been operated for more than 7 years. No signs of recurrence were found. This is the second case. A 42-year-old man had a papillary thyroid macrocarcinoma in the left thyroid lobe. Before MWA, a hypoechoic nodule with 10.0 mm multiplied by 6.2 mm multiplied by 9.9 mm in size and 319.2 cubic millimeter in volume was found in the left lobe, which was shown as the red arrow. The blood flow signal of the nodule is plenty in the color, which was shown in figure B. The CUS was performed immediately after MWA, which we'll see in figure C, and the area is completely contained the tumor. 1 month after MWA, the ablation area is 4,349.8 cubic millimeter. 3 months later, the ablation area is smaller. 6 months later is smaller than the 3 months. "12 months later, the ablation area was 87.1 cubic millimeter, and 18 months after MWA, the ablation area was completely absorbed, and a black line was left in the thyroid." Conclusion. So we can see the conclusion. MWA showed a good safety and efficiency in treating patients with PTMC and could be another choice for these patients besides surgery and active surveillance. In 2015, an Italian researcher had predicted that ultrasound-guided ablation may play a role in PTMC in the near future, and now it's becoming a reality. As for the future, we also have some visions. Will there be any changes to the guidelines in future? We have noted the development of radiofrequency guidelines for thyroid disease in South Korea in 2017. In 2018 and 2020, the Chinese Anti-Cancer Association and the Chinese Medical Doctor Association respectively released the expert consensus on the ablation of benign and malignant thyroid nodules. In 2020, European guidelines for thermal ablation for benign thyroid tumors were also developed. So, will the American Thyroid Association's ATA guidelines, the most famous guidelines in the world, change in the future? Just a few days ago, a new paper was published about thermal ablation for PTMC was published in Radiology. Professor Baek from South Korea wrote a commentary based on the paper, and he also noted that the thermal ablation could be a potential game changer. The current ATA guidelines were published in 2015. The last one was published 6 years ago in 2009. Now, 6 years later, the time is now 2021. Will the new guidelines will be issued this year, and will they be modified accordingly? Let's wait and see what will happen. Okay, that's all I have to say today. Thank you.
Okay, thanks, Dr. Chen, to give this excellent lecture. Okay, now let's move to the Q&A part. I just collected some questions from doctors. Let me see the question first. Let's answer. Please invite our doctors to answer the questions first. Then I will unmute all users. Then you can ask questions freely. Okay. Okay. Let's check the first question from Dr. Ibrahimi from Iran. What is the inclusion and exclusion criteria for PTMC ablation? 陈主任，您能回答这个问题吗？
哎，你再说一遍呗，没听清刚才。
就他问的问题是这个 PTMC 的这个应该是指的是适应症的标准吗？应该是适应症还是禁忌症的标准？
Is the it's usually now we usually ablate the PTMC as usually a single nodule and no cervical lymph node metastasis, and the FNA result was confirmed that it is a PTMC, not other type of cancer. OK。
稍等一下，我来把他们那个全解除静音吧，不然他们可能会有些问题。Okay, I will unmute all users, and if you have a question, you can ask our doctors. Okay, Dr. Ibrahimi.
Thank you for your answer, doctor. You use the subcapsular lesion, micro-PTC subcapsular, used to ablate it of this kind of micro-PTC?
If they when they are ready, that way you can put. When they are ready to do laser.
For subcapsular position.
Position. You mean
subcapsular? Yes.
If the position is in the middle of the thyroid, is the best position. But if in the age of the thyroid, we need to perform hydrodissection, especially when it's near the trachea and recurrent laryngeal nerve. It's the most difficult position.
Thank you.
I have a question, please.
Yeah, yes, please.
Hello?
Yeah, yes.
I have a question, please.
Yeah, please, Dr. Please, yes.
Yeah, my question is, how do we do the hydrodissection if the lesion, I mean the nodule, is on the isthmus? How do we place the hydrodissection to, protect the trachea and the recurrent laryngeal nerve and the esophagus if the lesion is on the isthmus, thyroid isthmus?
Did
you get my question?
他说的是怎么做这个隔离液，在什么时候我没听清，没太明白是在什么时候是需要怎么做隔离液啊
？Can you repeat the question, Dr. Joe?
My question is, if the thyroid nodule is on the thyroid isthmus, I mean the location is on the thyroid isthmus, how do we protect the trachea, the esophagus, and the recurrent laryngeal nerve from being ablated or injured?
With hydrodissection.
I know it's by hydrodissection. How do you do it? That's my question. I know you use hydrodissection to do it. How do you place the fluid, the normal saline, under the thyroid isthmus? That's my question. Because it's very closely attached. The thyroid is closely attached to the trachea.
Yes,
to
it's
avoid
possible.
injury to the trachea.
Yes, it's possible to dissect.
Is your question is the nodule is near the trachea?
Yeah, on the isthmus,
How do we do the
ablation.
dissection?
Yes, how do I want to know the practical aspect of it, not just you do it, you do hydrodissection. How is it practically obtained or possible? That's my question.
It's possible to dissect from isthmus nodule. We do it.
So what are the chances? What are the chances that the trachea is not injured? That's my question.
所以说你听懂了吗？他说的问题。
我觉得他的问题大概是，就是当这个结位于气管旁的时候，我们是怎么做这个液体隔离的？好像是。
有点像。
那你可以回答一下。
Okay, if you have such video, I would like to see the procedure, how the hydrodissection is being done when the lesion is in the isthmus. I want to see it. Theoretically, everything is possible theoretically, but in practice, not always.
没事，他说您这边有视频也可以，后面给我发出来也可以。他这个问题
他问是什么意思？是那个你很理解的意思。我听你几单词这样。
We have that video. Maybe sometimes we can show it to you.
Yes, I need to see it, please. Okay.
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 Thank you.
There's a question from Professor Navar from Morocco. What is the volume cutoff for using this technology of microvibration? 它应该指的是我们这个微波消融可以治疗这个范围，这个甲状腺的范围是这个消融的范围是多少？
For the benign nodule, the volume is no limited. But if the tumor is too big, we can ablate the tumor for 2 times of ablation. After the first time of ablation, about 6 months, the tumor became smaller and smaller, and it will be up from the chest. The tumor will up from chest, and we can ablate another time to ablate the tumor
at the center of that cell.
So for the benign tumor, is no real have no real limited. Yes.
Okay, thank you, Dr. Chen. 他刚才那个尼日利亚那人的问题是，应该就是气管峡部的那个是怎么做隔离的？崔主任。
对，我们理解是这样，但是他可能想要视频吧，因为这个
行 ，OK， 好的，行。
这儿好像有一个，我正在找，看看有没有啊。
Dr. Joe, our doctors are searching the video now. If they can find, they will share with you now, or they will send you later. Okay?
It's okay. Sorry.
Okay. Another question from Dr. Tofik from Egypt. What about the pre-ablation biopsy? 术前的这个穿刺应该怎么做？术前的这个活检。
Pre-ablation, we will give a core needle biopsy. Use the automatic biopsy needle under the ultrasound monitor.
好的。
That's all.
Okay. Yeah. I do have a question, Dr. Joe.
No, not yet. No more questions.
Okay. Another doctor from Professor Nava. How do you manage complications like hemorrhage? 怎么去避免这个并发症，比如说出血？陈主任。
Because the microwave ablation could stop the blood bleeding. So if you find that there is a bleeding in the operation, you can give a higher power, for example, 40 watts, to ablate the bleeding area to stop the bleeding. Also we also can give a careful color Doppler in the before you inject your antenna. It can help to avoid the bleeding.
Okay, thank you. Another question from Dr. Yari from Jordan. Should we re-aspirate normal saline after ablation finish? 在消融之后，是否要再次的去注射这个重新注册这个生理盐水？
We didn't do that because if there is a heat injury, it had occurred when the ablation finished. It's not necessary. We will give an ice bag to give some pressure to protect the heat injury. So we did not do the inject the saline again. That's okay.
For how long we follow up the thermal lesion for PTMC for lifelong? 就是他多久要去 follow up 这个 PTMC 的这个热
Okay.
PTMC 的这个
after the ablated area was completely absorbed, we usually perform every 1 year to perform an ultrasound to detect the thyroid, to see if there is any new lesion in the thyroid. That's all.
Okay. And another question from Dr. Tofik from Egypt. What about the ablation of the recurrent after surgery? 复发率应该指的是。复发率。这个。
Okay. Last month there is multi-center research published on radiology. The recurrent rate is about 1%, but no, there is about 800 tumor was ablated. Only about 8 patients have the recurrence, but there was no local recurrence, and most of them is new lesion was found in another place in thyroid gland, and there also have one patient had cervical lymph nodes by metastasis. That's all.
Okay, thank you, Dr. Ben. Another question from Ibrahimi from Iran, is it possible to mix the alcohol and microablation in the same lesion, in the same session? 有没有可能在同一个手术上去用酒精，这应该是酒精，
它是那个乙醇跟微波消融一起结合。
If the nodules are simply cystic, we will use the thermal ablation combined with microwave ablation.
Okay. Here's another question. What is your technical point to prevention of hemorrhage during procedure in cyst solid nodules? 就是在这种cyst solid nodules 这种手术过程中怎么避免出血？应该指的是那个 cyst 那种，应该是指的是是有液体的吗？是囊状的那种结节消融，怎么去避免出血？
是囊状。囊性。
等等。
我没看着那个问题在哪儿呢？那个
你能看哦？我来发一下啊。在囊状的这种结节上面的消融时候，怎么避免出血？因为它里面有液体，对吗？
For the septic nodule, we usually inject a needle and absorb absorb the cystic from the nodule. After that, we inject some alcohol to avoid the bleeding. And then before we withdraw the needle, we insert the antenna into the nodule and start the MWA to reduce the chance of bleeding. After the ablation was complete, we pull out both of the two needles.
Okay, thank you, Dr. Chen. Anybody else has questions? You can ask here.两位主任，我们再等一下，他们可能还有问题，我们再等一下。
好的，好。
我们这边在找那个视频。
يا بابا كثير حلو ده ما بيزحط ابدا.
Hello, everybody. Hello, everybody. You can hear me?
Hi. Yeah. Yes.
Yeah. I would thank Xu Kenyon and Think Tank China for this presentation, and I would say for Dr. John that hydrodissection is very easily. I understand your question when you say that trachea is very closed of the nodule. But when we does hydrodissection is really very easy, Dr. John. We did it many times. It's not very difficult, really. We do it in retroperitoneal space, which is very hard and very closed, and it works. For my question is for the size of the noddle. What's the cutoff of size of noddle that we can do this technique, and we can have real results? This is my question, if you understand me. You can understand?
他是不是说还是说这个透气气管的这个
Yeah, the size. Yeah, the size of the
大
noddle.
小什么最适合的意思。professeur là douille, je suis là. Vous pouvez parler français, je vais traduire.
Ah, très bien, ok, c'est bien, c'est mieux comme ça. D'accord. En fait, ce que je demande, c'est que quelle est la taille limite, seuil qu'on doit choisir pour des nodules pour avoir de bons résultats. Ça veut dire que si je choisis cette taille...
Ça veut dire, vous voulez dire quelles sont les tailles plus appropriées, ça non? Plus adaptées. C'est ce que vous voulez dire?
La taille à partir de laquelle je dois faire cette technique.
就是说这个技术嘛，所以主任你好，就是他说这个技术用什么时候用这个技术最好，就是那个甲状腺结节的大小是最适合的。就是说有没有适应症？对，这是适应症，对，
是问的适应症，
就是说这个甲状腺结节的这个那个微波射的一个范围，对，大小的范围。
For benign tumors, I just say for benign tumors, is normally controlled. It's normally have no real limited, but in our hospital we have treated a tumor about 10 centimeter. But if the tumor is too big, it will take many times, take a lot of times to perform the MWA. So you can take this in your mind. Okay. But if for the smaller tumor, it's no limited. Another I want to say is the tumor at the retrosternal. Yes, if one half of the tumor is in the chest, it's very difficult to have to complete the ablation. So we can take it to two step. First step, we ablate the upper part of the tumor. About 6 months later, the upper part of the tumor was absorbed, and the
second,
yes, the tumor, another part in the chest will upper, and you can ablate it easier. This is for the benign tumor. For the malignant tumor, we usually ablate the PTMC. It means the tumor is papillary type, and the tumor is less than 10 millimeter. But for some other hospitals, they have tried to do some research to perform the ablation for TEB, T1B. That means the tumor is less than 2 centimeter. But I think when the tumor is bigger than 1 centimeter, it will more difficult to complete the yes, because the malignant tumor is harder, it's more harder, it's more difficult to insert, and maybe it can cause a lot of complications because it may close to the trachea or ventricular or recurrent laryngeal nerve, and it's more harder to perform the hydrodissection. That's all.
There is another question from Dr. Tofik. Is there a special approach for retrosternal? 就是胸骨后面的那个是否有一些特别的一些穿刺路径？
这个刚才我已经跟他说过了，这个我刚才跟你说了。
OK， 好，行 ，OK。Any other question? If you have a question, you can also send an email to us, and then I will get answer from Dr. Chen and Dr. Sui. Okay? This is my email address. If you have a question, you can send me by email. We still have time, so please do not be shy to ask questions. 他们似乎现在没什么问题了，两位主任。那个我替他们问一个问题我替他们问一个问题啊，因为我们每次这个会议的时候都会有那个医生会要那个 PPT， 这个有没有可能去跟他们分享？
可以，我这边可以没问题啊，这想要可以给，没问题。
水主任你这边 OK 吗？
没问题，就是刚才那个尼日利亚的那个，他不是要那个视频吗？也可以到时候要个邮箱，到时候给他，是吧？
对。
好，行。
没找到，没找到。
Okay, the two doctors from China, they are willing to share their presentation later. Then I will send all of you their presentations so that you can start it further. Okay. So thank you, Dr. Chen and Dr. Sui.
Thank you.
Okay, the time is okay, and we thank you, Dr. Chen and Dr. Sui, to give such excellent presentations, and hope we can introduce our microwave ablation technology to more countries to benefit the patients. Okay, so if you have questions, you can send an email to me, and I will send the presentation and the videos that Dr. John needed to you. Okay, so thank you everyone to join us, and see you next time.
Okay, see you
everyone.
Thank you. Bye bye.
Bye
bye. Bye bye. 谢谢两位主任。OK， 拜拜，豆豆。OK。
其实刚才没有。